Hey, what's going on, guys? This is Dan from Fitness Pain Free. We have Dr. Sean Rockett here, my favorite orthopedic surgeon here. How you doing, Doc?
I'm doing great. I'm doing great. Thanks for having me.
Okay, very good. I want to just go ahead and get right into the question here. One of the issues that I'm having a lot, and this is happens in the shoulder, but other parts of the body too, is that people will get a serious injury. They'll go in, they'll get imaging, they'll get MRI, and they'll find, let's say, a rotator cuff tear or hip labral tear or something along those lines. And then they come to me, they say, hey, Dan, do I need surgery for this? Because what happens with a lot of these individuals, it seems, is that they get something, it's very painful, and over the course of several months, they slowly get back to their activities and they're doing all right. Some of the research, I guess, shows that the rotator cuff tends to continue wearing and tearing over time, and whether or not this becomes an issue, I don't know. So when people ask me this question, I have a tough time answering it. So I wanted to shoot that over to you, Doc, see what you thought.
Yeah, sure. There's a lot of factors, obviously, that goes into decision making for surgery, especially with rotator cuff tears. And I think most commonly you can break them up into full thickness rotator cuff tears, and then there's partial rotator cuff tears. Full thickness, I think there's pretty much agreement in the orthopedic community that they're going to get worse, most likely over time. Again, it depends on the age of the patient, the activity level of the patient, the size of the tear. Personally, if I have somebody who's symptomatic too, and you can break these up into a number of categories, but if somebody's symptomatic, meaning pain that hasn't gotten better, or weakness that is significant weakness, then that puts that into a more of a surgical category, where those people, if they've tried conservative measures, things aren't getting better, they've tried therapy, they've modified their activity, and they're just at a level where they're having pain, trouble, reaching up over their head, trouble with activities of daily living, then that's, certainly an indication for surgery. There are, on the other hand, people who are symptomatic, have full thickness tears, and say, I don't want surgery, and that's fine. I'm never going to drag anybody to the operating room, or, they sign consent, and people get worried that when they sign consent that I'm going to, knock on their door. But if they change their mind, say their symptoms go away, they have a full thickness tear, their symptoms go away, what do you do then? They're feeling better, they're feeling stronger, they're feeling like they can do stuff. Then what do? I would argue for those people, if they definitely want to avoid surgery, to be monitored over time. So there are people that come back to the office with a full thickness tear, and they've said they didn't want surgery, and then a year later they come back and they go, I'm having trouble, it's painful again, it's painful now, and then there's been a significant retraction of the tear, meaning that tendon, has pulled away, and, the tendon unzipped and got bigger without them knowing it. So sometimes people can get tears that they don't know get bigger, meaning like a tear that all of a sudden becomes bigger. They don't know it. And then we come back, do a follow-up MRI, and you're stuck because the tendon has retracted. You get atrophy, weakness, and then sometimes it becomes unrepairable. And those are the situations that you really want to avoid.
How tough is it to repair those retracted tendons, and are the outcomes worse generally?
Definitely. So if you get that tendon, here's sorry for the graphics here, but can you see?
It's good.
If here's the tendon and you have a small little tear, that's a slam dunk surgery. All you got to do is do this. But if you get into where the supraspinatus then becomes infraspinatus, then becomes teres minor, you get all three. Can you tell? Can you see?
Yeah, that's pretty good.
All three come off. You then get atrophy of all those other muscles. This tendon over here becomes cement-like, and it becomes very difficult to bring it back to the top, because we know that tissue is not normal. Once you lose that attachment site, you lose the blood supply, and it becomes very fibrotic, very stiff. And then once you get atrophy, where the nerves stop working because there's no connection to that muscle, it becomes difficult to reattach. You could reattach it, but studies have shown once you develop atrophy of those muscles, where you see it on the MRI, you see the muscle degenerating and becoming fatty replacement. There's fat that goes into the muscle. Once you get into that, the surgery becomes very difficult and maybe not even very helpful.
Mm-hmm. All right. So I do have a couple patients that I work with that have kind of low-grade pain in their shoulder most of the time, and they're diagnosed with, let's say, a small partial thickness tear.
Yeah.
And, they have trouble with specific things, and the pain kind of comes and goes, and it's not too big a deal, but it does interfere to a small degree.
Yep.
I feel like a lot of people, especially in CrossFit, are dealing with that on a regular basis. How would you handle a patient like that?
So yeah, that puts us into the next category, which would be partial thickness tears, which again, here comes the diagram: supraspinatus, ball, tendon pulling. The articular side is down here, bursal side up here. A bursal-sided partial tear is much more painful than a articular-sided partial tear. So you can have a partial tear, but if it's a bursal side, we know those have a tendency to progress more, and then I'm more aggressive with a bursal-sided tear, meaning that the top of the bursa versus the articular-sided tear. Again, similar thing, if someone has a partial tear and it's a very small partial tear, those people can wait. There's no sense of urgency. Everything is attached and it's not disconnected. You get into issues when it becomes disconnected and things start to unzip. And that's what we try to avoid when you get a full thickness tear. But for partial tears, people will say, if here's the attachment site, where are you here? If here's the attachment site, we go by 50% of this attachment site. If something is torn, hanging on by a thread, those are ones that we want to repair because they're, you can reattach a lot more. If something is less torn and there's a small, less than 50% tear, then those can be watched or debrided. Those don't typically need to be repaired.
All right, because I've had a few friends, a lot of CrossFitters, and they had this kind of aching pain over time. Finally decided to go and get checked out, and they did have a full thickness tear, and they really had no idea. Some of them were hitting like PRs in their jerk, and with a full thickness tear. I guess it's hard to know what kind of damage you have going on. For these individuals that do have a little bit of pain, would you recommend them going every year or so to get it checked out? I know we start to run into problems because MRIs are expensive. How do you best proceed?
Yeah, it's tough if somebody's PRing their jerks and PRing things to tell them you need surgery. That doesn't make sense. But yeah, I would monitor them. I would do a follow-up MRI on them to see if there's been progression.
Yeah, it seems like some of these people, they're very functional, but they still operate in a lot of pain, I guess.
Yeah, I'd say the people that I've seen like that are the younger people. Like, rotator cuff tears, we know progress over time. As you get older, there's just degeneration that takes place over time. So it's very common for people over the age of 70 to have rotator cuff tears. But for the younger people, age 40, 45, if they have a full thickness tear, I've found that, and it's a small one, I've found that they can compensate based on their musculature. So they might not be as symptomatic. But certainly those are the people that you worry about, because if they then go on to unzip everything to pull back the rotator cuff, those are the ones who get into trouble if, in fact, then they have a retracted rotator cuff tear that might not be fixable. So that's the tough part.
Okay, so let's say you do have a 25-year-old that gets a tear with the shoulder, kind of rehabs it a little bit themselves. Still has pain over the course of the years, and now they're getting into their 30s, 40s, 50s, and they don't do anything about it, and the shoulder gets really bad. What would be the worst case scenario for someone who kind of ignores everything?
Yeah, so worst case would be you have a tendon, and 25, it's not going to happen with a 25-year-old. Rotator cuff tears are typically 40 and above. I would say 40 is very young for a rotator cuff tear. It's more 50s and things like that. But for a younger person who has a retracted tear that is atrophied, You're talking about a tendon transfer, of the lat dorsi or the pec major tendon. So something that is not a guaranteed success and can be difficult to rehab, and which again is the reason why you want to be not aggressive, but monitor and be careful with those people.
Okay. Any thoughts on some of the injectables, some of the PRP stuff, some of the stem cell stuff? Any thoughts on those treatments?
Yeah, I think as we've seen more and more, people have been using the PRP for to augment the repair, to think that it would help, and people did worse with the PRP injections after a rotator cuff repair. I've seen them more for tendonitis and things like that, the PRPs being more successful in that, and the literature sort of supports that. But yeah, this is, again, it's like a cable. You cut that cable, it's going to pull away, and no PRP injection is going to take that tendon and reattach it. It's just a mechanical tension pulling away from the bone.
Would it help repair maybe some of the smaller partial tears, or is it?
Yeah, again, if you have that tendon, once it pulls, there's tension on that tendon, there's tension on the muscle. It doesn't bring it back. It doesn't reattach it.
Okay. So some of these are not quite going to do it, I guess. What do you? Well, I guess I have a question for you. There's a couple local docs that like stem cells around where I'm at, and they're putting stem cells everywhere. It's like knees, spine, rotator cuff. If these are effective, what mechanisms do you think they are affected by, if they are at all?
It could be tendonitis. People are getting the injections for tendonitis. So, we know that tendonitis is going to get better no matter what we do. Yeah.
That's interesting. I will share this little story, just because I think it's interesting, and the stem cell stuff is getting a little bit bigger, especially where I'm at. And a lot of times some of the docs are sending them to therapy. I had one individual that had a rotator cuff tear on his left side. He was like a 60-year-old man. He was a CPA. He wasn't like an intense exercise guy. He liked to scuba, right? That's what we want to get back to. And he had his rotator cuff repaired on one side, and several years later was advised to go through with the same surgery on the other side. Decided not to. He had stem cell injection into his shoulder, his rotator cuff. He kind of had the typical presentation where nice little shrug and wasn't able to bring his arm up overhead.
Big tear.
Screening for him the first few, I would say it's probably about 12 weeks. He wasn't getting any change whatsoever in the shoulder. And then he came in one day and I was like, well, how's your motion? He just like went all the way overhead. And then it kept getting better over the course of the next few weeks. And then that was it. He got better. I discharged him, and his range of motion was better on the stem cell side than the surgical side. And I don't know. I just kind of took it for what it was, but it was interesting to see that.
Yes. Was it an acute tear? Was it a traumatic tear?
I don't know. I didn't ask many questions about that. I actually ended up trying to call the doc. I don't think the doc ever got back to me, but
because typically if you have a traumatic tear in an older person and you get that, that shrug, typically you can get the arm back up within probably 2 months, 3 months by recruiting everything out, by recruiting the deltoid, by recruiting all the other muscles. So that, with therapy is certainly a reasonable treatment. I'm sure he was still weaker on that side, and I'm sure the cuff didn't reattach.
Yeah. Okay. Yeah, I was curious because I know with like the massive rotator cuff tears, there's some research about physical therapy for the massive tears, and they tend to get better too. So one of those things over time, they just all tend to get a bit better regardless of what you do. I was just curious if we thought about those things. People do ask me those questions too, and I have a hard time answering them. So
certainly, yeah. There are a lot of people with the massive tears. They come in and they can't, shrug up. They'll get it back with therapy 2 to 3 months, but their strength is not going to be normal, and the tendon, is not going to reattach. But
any new or exciting surgeries going on out there that you think have a lot of promise?
I've been doing sort of shading more towards the subpec tenodesis for these older biceps tears, when I've been having some pretty great results with them, doing a little small incision, anchor repair, suture anchor, as opposed to drilling a big hole in the humerus, and getting people, back to pretty high stuff at, about 4 months or so.
Good. This last one's more for me, and I'll let you go. I don't want to get too much of your time, but the couple local docs, they love Tenodesis. Seems like they're doing it, with most repairs. Is there a big advantage to that versus not?
So, I would say, for a slap tear, type 2 slap tear is the indication for it. And I think we've seen more in some of the more recent studies that the over age 40 trying to repair the slap sometimes leaves the results not as good, whether that's stiffness or pain. Sometimes people are not as functional as opposed to doing a tenodesis. And that's what I've seen. I wouldn't, certainly you got to be sure that you pick the right reason to do the tenodesis, and you don't do a tenodesis on everybody, but you have to have the pathology of the superior labral tear, to go along with it, pain, radiating down the front into the biceps. The cuff has to be pretty good and pristine, in order to do that, or during the repair as well. But I found that the success and the pain relief are pretty good with it.
Oh, pretty good general. Okay.
With minimal, disability or function. Again, older people, not younger people, older people over age 40, 45. And again, I've had people getting back to CrossFit and overhead activities with no symptoms.
Oh, yeah, pretty good. Yeah. I didn't really introduce you too good, but Dr. Rockett does CrossFit himself and works with a lot of CrossFit athletes. So really value his opinion, and I think it's very relevant. One of the problems I see is that most docs out there aren't really on your side if you're a CrossFit athlete or just like heavy lifting. And then I wonder when docs come and they say, hey, get the surgery, it'll get you back to where you need to be. Well, if I want to get back to doing heavy overhead squats and jerks and muscle ups, is that really going to get me there? So I really value your opinion, because where people are trying to get back to, whereas a lot of docs, I don't think they know that as much. No fault of theirs, they're just not in the realm. So appreciate it, Dr. Rockett.
Well, my pleasure.
Yeah, very good. And I'll let you go, and thank you for everything.
Sure.
Okay.